So for this talk, I'm going to talk a little bit about PATH because I'm not sure how much people know what we do, our perspectives on it, and then sort of narrow down on work in diagnostics, which is what I work in right now, among other things, and then talk about the perspective we take. I'm not going to be showing new technologies because that's not how I think about it. I view laboratory testing and new technologies as sources of information that have to be used in systems. And so you're going to get a little dose of anthropology, like it or not, today, and maybe broaden your perspective on how we go about tackling what are often daunting problems. So about PATH, we've been around 30 years. Most of you probably don't know that. Started in Seattle. We have offices in 18 countries. We've worked on over 1,000 projects since we were born, literally in someone's garage. Just by the way, our initial project was funded by the Ford Foundation because condoms in Southeast Asia were deemed to be flawed. The manufacturing processes were flawed. So some of our initial projects were to improve the manufacturing processes for condoms in South Asia and Southeast Asia. We've worked in over 100 countries. We have 650 staff, although we seem to be growing virally these days, and that we're growing by about 25% a year. And about half of the staff is overseas. So our mission, these mission statements are often, I use this because it's illustrative, but most of the time these mission statements, if you read the University of Washington's mission statement, you wouldn't understand it either. But our goal is to improve the health of people in developing countries by advancing technologies, strengthening systems, and encouraging healthy behavior. So I'm going to talk mostly about advancing technologies, although we work in all three areas in very deep and long-term ways. And it makes us a little bit different than other NGOs because we did start out with a technology focus, and we have people on staff like engineers and biochemists and business development people who think about things from a product perspective. So our role in technology development is several. First, we're an innovator and inventor in that we have a shop and a lab, and when people go on tours of PATH, they see that we have engineers and immunologists and molecular biologists and others working on things, and that we develop tangible things that we think have appropriate application in the developing world. Given our name, we think they're appropriate. Also, we act as a facilitator and a gatekeeper in that we work with the public or private sector to bring technologies to the developing world. So there's often technologies that languish either in universities, and University of Washington is no exception, or in industry that have a use here or in Europe or other parts of the world, but the use in the developing world hasn't been realized. And because this is what we do full time, we see uses for things that are a bit novel. The other thing we do is that we take complex things and we make them more simple, so for use in the developing world often. So we take technologies that often are complex or require things like cold chain or have many steps or are expensive and try and find ways to make them more amenable to settings that don't have as many human capital infrastructural resources. So just to give you some ideas of things we've worked on, if you look up in the center picture up top, the auto-disable syringe, and if some of you are clinicians, you probably have used some of these. These are, it's basically a one-use only syringe that was invented at PATH, licensed to Becton Dickinson and others, and there's been over 1 billion in use now around the world. This is a big step, obviously, in lots of the developing world in the 70s and 80s, especially these major vaccine programs were using glass syringes that were reused. And it's unclear what the spread of things like hepatitis B and HIV were, although we think that it's probably non-negligible. We don't think it's probably the primary spread, but we think that it was probably fairly important. We also worked on, in the bottom left, on vaccine vial monitors, and this is actually a partnership with a meat packing company, a company that had developed a temperature indicator for heat stress for ground beef. And we saw them at a convention, as the lore goes, and we said, this would be interesting to have on vaccine vials because once the vaccine is created in the factory, as it goes out the door, if it's not kept at optimal conditions, you can have either through freezing or through thawing or through heat, you can have diminution in its activity. So those are on, I think, 45 or 50 of the 71 WHO approved vaccines. And they're in the billions each year used. And if you see vaccine vials in the developing world, almost anywhere now you'll see those. The other thing we worked on was the Uniject, a simple delivery system for vaccinia, given that a major time crunch for people giving mass vaccines is the fact that you have to dilute and draw up vaccine from the vials, from the lyophilized materials that are diluted. So we actually created this bandolier system where people could tear off 6, 7, 10, 20 single-dose syringes to give vaccines in the field relatively quickly, and they're easily disposed of. The other thing we worked on, we are working on, and these projects are generational, by the way. These are not things that happened in a year and we sort of threw it over the fence and now everyone used them. And that'll be sort of the theme of my talk. But we also were very interested in female-controlled barrier contraceptives. There are very, very few out there, very few accepted methods out there. We worked on the Silks diaphragm. We developed that. The big problem with diaphragms is that sizing, so you have to go to a clinician to get sized, which is wasteful because you have this stack of diaphragms that they have to sort through to find the one that fits you, and then correct insertion. And so we developed a one-size-fits-most diaphragm that actually is spring-loaded. And we've been through clinical evaluations obviously for prevention, for fertility prevention, but then also for pregnancy prevention, but then also for prevention of STDs at the cervical location. We're also working on the women's condom. Big problems with that were insertion and also user acceptance in that sound, noise, comfort, and the ability to deploy it correctly every time were problems. So we've been working on things like that. Now let's move on to diagnostics, because that's mostly what I'm going to talk about today. So if you look on the far left, the ICS test, immunochromatographic strip tests, we really started working on dipstick assays, so very simple immunoassays in the middle 80s. Obviously, pregnancy tests that you buy today. I don't want to tell you how much it costs to actually manufacture those pregnancy tests you see in the drugstore, because you'd be appalled at the markup that people are selling these things for. Probably less than a dime, and they're selling them for $10 to $12 each here in the U.S., so FYI. We worked on suites of these because we thought this was really interesting matrix to diagnose things like HIV, hepatitis, malaria in a simple format that is becoming more and more normative, in that people understand how to use them. They don't require refrigeration. They're usually 5 or less steps, and they're inexpensive. All the materials are commoditized at a certain level. We also worked on surveillance tools using ELISA, so standard ELISA formats, but for conditions that are common in the developing world. The thing you have to realize here is that all these technologies really exist. It's the analytes to go on top of them, the targets, that are missing in a lot of situations. So for ELISA, there's lots of room to put targets on, or combinations of targets that are useful for the developing world but don't necessarily have markets in the Western world. The other thing we're working on, which is sort of, I don't know, it's the hot thing we're working on, and I don't know where it'll land, but we're working on miniaturizing and moving. I use lab on a card as an example, but we're interested in simplifying and miniaturizing molecular diagnostics in real concrete ways. So finding ways to move really sensitive DNA or RNA-based diagnostics closer to the patient in the developing world at a cost that's relevant for people who live on less than $2 or $1 a day. And we think that we can do that given the cost of goods and, as you can imagine, the patent landscape that is coming undone as we speak, so given the age of molecular diagnostics. So here's some products. This is just to give you an idea that we've been working on this for a while. If you look at the red strip on the top, so we have R&D, validation, which is a two-sided arrow, because in most cases we have, I like to call them brilliant failures, in that we go take things out to the field in a first-generation prototype, and things don't go as planned, but we learn a lot, and it goes back to R&D to get re-optimized. Tech transfer, so we don't actually ever manufacture anything we make. We transfer it to commercial partners, hopefully locally in developing world areas that are closer to the populations that we hope to serve. And then commercialization in that they sell these things to the public and private sector. And I'll give some details about that later. So we've worked on a lot of different things. We developed one of the first HIV rapid tests back in '91, right as people were starting to realize the severity of the epidemic. And it's unclear to me, I've asked several people whether or not it was serendipity or whether it was someone had foresight, and no one seems to want to give me an answer. But we worked on things like on a lateral flow, on a rapid strip test format, malaria. Our commercial manufacturers sell about between 3 and 5 million of these a month now around the world, worldwide distribution. Hepatitis B. We worked on TB dipstick for better or worse using a serological an immunoassay that was actually discontinued. Syphilis, and there's several companies that make syphilis rapid tests. And then in earlier sort of bins of effort, we're working on gonorrhea, chlamydia, Japanese encephalitis with commercial partners, Chagas disease. We're looking at TB mods, which is drug-resistant TB, hopefully more rapid and cheaper way to monitor drug-resistant strains of TB. And then in the R&D phase, we're looking at things like CD4. Obviously, many of you know that with PEPFAR, there's been this massive movement of drug to the periphery to manage HIV patients, particularly in Africa. There's been a lag, though, in actually being able to gather the laboratory data to make informed decisions about how that drug gets given out, how it gets delivered, and how it gets managed. So we're working on and flow cytometers, to be totally honest, are not the answer for a lot of reasons. So we think in the long term that there needs to be even semi-quantitative approaches that give clinicians valuable information so they can make decisions in the periphery to at least triage patients up the ladder. We're working on card-based assays, so multiple parallel analytes with one sample, so multiplex diagnostics for enteric disease, so diarrheal disease, febrile illness, because fever is commonly presumptively treated with antimalarials, so trying to figure out ways to have people unpack this sort of presumptive management of malaria in a way that's relevant to the drugs they have and to the ability of the patient to pay and consume. And then STDs is a project that I run where we're looking at 4 different STDs and flora derangement like bacterial vaginosis using a single self-collected vaginal swab. And then now we're also looking at infant HIV. We're developing P24 tests and also infant HIV PCR tests. So this gives you some idea of the range. And all of these things, we have 10 to 15 projects ongoing at any given time. So it makes your head spin. So why do we do diagnostics for the developing world? I think a big reason is that diagnosis is often carried out without diagnostics. So in the periphery, especially in the developing world, patients are often managed syndromically, which results in a large degree of misclassification. And for what my background is, which is in STDs, most people have asymptomatic disease. So it's very difficult to get a handle on the clinical presentation and the rationale and the heuristics that people use to prescribe or manage their patients, prescribe drugs or manage their patients. The other thing is that we can actually make a difference here, we think, because less than 5% of total expenditure contributes to nearly 2/3 of all clinical decisions. So less than 5% of health budgets are going towards diagnostics, but it contributes to this massive amount of what clinicians actually do. So this is actually an opportunity for us, hopefully in a non-disruptive way, to provide value to clinicians in real time. And then obviously resistant and emerging pathogens are a growing problem, and what happens in Indonesia and Vietnam with avian flu does affect people here. So there are multiple reasons to be working on this. And things like Chagas disease, for example, given the massive migration of Latinos to people from Central and South America to Washington State, there's a non-negligible prevalence of trypanosome infection in Washington State. So things to keep in mind, that these things are connected at a certain level. So there's a lot of obstacles to the the products that we develop, and they provide the constraints under which we work to develop product specifications. So obviously one is, I'm going to talk about each of these in detail, but infrastructure being a major one, staff training and caseload, logistics and maintenance, purchasing power and patient loss, and then what I like to call the private sector mindset, which is the aversion of companies to think about working in the developing world for a whole host of reasons. So infrastructure, this is actually a picture taken by one of my colleagues in a private sector lab, actually a fee-for-service lab in Delhi. So this is actually a lab that's for middle class folks in Delhi, in India. So common characteristics, and you see they have centrifuge, microscope, running water. Obviously they're doing some sort of staining in slides, as you can see in the foreground, but not much else. And so intermittent electricity, no or contaminated running water, a deteriorating physical plant. So the roof over your head may be leaking, or there may not be climate control, for example. And then poor hygiene. So contamination is an issue. And then staff training and caseload. In at least in urban and peri-urban areas, the patient burden per clinician is immense. In that I did a qualitative study in Delhi and in Rajasthan in India 3 years ago, and I actually timed the amount of time that each clinician would spend per patient, and it was less than 3 minutes. It's actually probably not far off from here, to be honest, but no offense to you in the back there. But so people aren't getting much time with patients. So what we're trying to do is leverage that interaction, and when people walk out the door, they're gone. And how do you tracking someone down for follow-up is difficult. I'm actually getting ahead of myself. But in some cases, not all cases, there's poorly trained and equipped staff, and that clinics serving the poor, which is where we work, usually have the worst equipment. They're most ill-suited to do anything that has any kind of level of complexity. And doctors and nurses realistically don't prize these positions at a population level. There's obviously exceptions to this, but most people would rather be in a capital city where there's research going on, where there's exciting things going on, where there's advancements going on, rather than in areas that don't have a lot of infrastructure. And they're also, to a certain degree, hamstrung by what they can actually do in terms of intervention for their patients. Logistics and maintenance, this is actually, these are actually rapid tests on the back of this bike, if you can believe it. Poor distribution systems, and that doesn't mean that people aren't trying to move things from place to place. It's actually just getting it there is difficult. Improper storage conditions of supplies, so climate control, especially for diagnostic kit reagents, is a major challenge that we face. There's not a lot of budget for upkeep of capital equipment, so people don't have a lot of money to maintain things after they get them. So you have to be really careful about what you convince people to buy. And you have to find ways for people to buy something that they can use for several purposes. So they can dip into several budgets to maintain it, also that they can amortize it and pay down the cost of the device more quickly. And then something that no one talks about, but we see a lot of, is no safe hazardous waste disposal system. So I was just in Hyderabad in India. We're doing a study on drug-resistant TB. They had a hood that they built that for processing sputum samples that vented right out the wall, but there's no climate control and the windows were open. So what you're having is this cycling of air back through. I mean, it's a great effort, and I think it was, the intent is amazing. It's just that there's not a simple way and an inexpensive way to manage biohazard in developing countries, which is something that people don't talk a whole lot about. And then purchasing power and patient loss. Health institutions are reactive in that they're characterized by chronic budget shortfalls, in that they have a finite pot of money. The people who work in government are often on short tenures, and so they are using roads money to pay for schools and schools money to pay for health and so on, and there's always one that's left out or one that's underfunded, or all are underfunded. And then patients in most need are usually poor. Have no expectations, and this is an important point, and I think this gets to the heart of a lot of what we're working on, is that there's not necessarily an expectation for service from the public health system in large parts of the developing world. And I can't make a generalization about everywhere, but the places that I've worked, you don't see people expecting much from public health providers in the developing world. And increasingly, in large parts of the developing world, they have more choice. Growing private sectors, things like pharmacies, private doctors that charge reduced rates. So they're actually thinking about what they expect from the health system, how long they're willing to wait, and then they're making their decision on care based on a whole bunch of different decisions that have to do with their family, their ability to pay, how much time they have, et cetera. And then obviously there's high opportunity cost for clinic visits, as I was talking about. And when you lose a patient, when a patient walks out the door, in many cases it's difficult to get them back. It's not always true for all diseases, but for most diseases, once they leave, it's really a challenge to get them back in the clinic for follow-up. So, and then the private sector mindset, which is many private sector companies don't have a deep understanding of developing world markets because they're focused on places like US, Europe, and Japan, for example. They worry about this. This is the thing that I hear the most, which I never understand. I guess I understand it intellectually, but I don't understand the reality of it. They worry about the safety of their IP. Everyone's convinced that they're going to send something overseas, and then someone's going to reverse engineer it, and there's going to be 50,000 of them for half the price, and they're going to be closed out of a market. And to be honest, this doesn't happen as often as you would expect, especially with diagnostics. They don't see the lucrative potential. What they see is the lucrative potential is in volume, getting large numbers of patients to come in and use their service. And there's a disconnect there of thinking, gosh, how are we going to get all those people to come in and use our service? And the only way we're going to make money is if we get economies of scale up to a certain point. So it's difficult to get people to get over these humps to say, yes, we want to be involved. So we have to incentivize them, which I'm going to talk about. And then especially for small companies that are venture capital funded, for example, it's hard to distract. They don't want to be distracted from research and development on reimbursable diseases. So an anonymous example I have is that we're working with a company right now that their venture capital and their board has said they want a prostate-specific antigen test, and that's going to be their road to market. Not that there aren't a few out there. But we want to work with them on developing tests for things like malaria, for example. And their board was very reticent about this because their board wants a return on investment as soon as possible. We think they have a technology that's interesting. So you have to create an amazing case to get people who have invested $5 to $10 million, $20 million into an entity to say, yes, you can take some of your attention away from PSA tests, which get reimbursed at, I don't know, you guys would know better than me, to cell tests in the developing world for malaria at $1.25 a throw. So there's a mindset here that we have to break down, and it usually doesn't happen all at once. It's kind of like peeling an onion. You have to do it slowly. So all those constraints get us thinking about the ideal diagnostic product specs. So we want to minimize assay steps. If you can, it'd be great to diagnose several things at once. We'd like a rapid turnaround of results, but that's all relative to what disease you're working on. For example, for something like tuberculosis, where drug susceptibility testing takes 40 days with standard culture, if you can get it in 2 weeks, that's better than nothing. That's an incremental gain that you can pass on to the patient. We'd like to have comparable accuracy to the state of the art, although it really depends on patient characteristics and on what the standard of care is. So this is a relative term, something to keep in mind. Affordable, and I was going to put a question mark there because affordable really is relative to what people can pay and what ministries of health, for example, are allocating presently, for example. No special storage requirements, so we don't want someone to have to ship things around at minus 70 or even at 4 degrees. We want a long shelf life, so this is one thing we rarely budge on, and that is that we want something to be able to sit on a tarmac in Lagos, Nigeria at 40 during summer, during the warm season, the dry season, and survive and be viable. We want something that can live for at least a year and a half, so people aren't using expired tests, and people don't feel that they're not getting something for their investment. We want a safe disposal method as possible, and then if they have instrumentation, we want to make it as inexpensive and possibly portable, or have a small footprint, have a small area that it consumes in a lab or in a clinic. So at PATH, we take these issues, these specs, and these problems on primarily by working with private sector companies, but also people in academia, and in many cases, and both of those at the same time. We have a multidisciplinary team-based approach. So in every team, there's someone like me, a field person. There's a technical person, engineer, biochemist, immunologist, molecular biologist, whatever, mechanical, electrical, civil engineer. There's a business development person who's saying, you're really violating patents by doing what you're doing. And a lawyer, which is important to have. And then someone who says, we really can't afford to do this, so an administrator. So on every team, that's how we take these things on, because you need different opinions early on in the product development cycle to create something that lasts. We use a product cycle model, so we actually create timelines for ourselves about how quickly we want to create, we want to optimize technologies, or we want to improve the way we do things. Obviously, those are organic. And then we have intimate contact with the field. So at very early stages, we are going to the field with prototypes and talking to people who actually deliver healthcare to understand their daily lives, because we have to fit these things into their daily lives rather than disrupt their daily lives. So there's 4 critical elements to how we take these things on. This is part of your CME requirements, so you can start scribbling at any time. I didn't realize I was going to have to create a quiz for this. This is bizarre. So we need to understand the needs of vulnerable and at-risk populations. So we need to understand who's out there and who we're going to serve. We need to create incentives for technology development. The idea that you can build something and people will come is farcical for developing these things for the developing world. It doesn't. You can have the best technology in the world, but you have to advocate from the very beginning to make this worth the effort to change their behavior for people to use this in a long-term way. You got to build the evidence base, so you can't just say it's the next best thing. You actually have to demonstrate it locally to get people to use it. And you have to strengthen, as much as you can, strengthen systems for distribution, delivery, and use. And I'll talk about each of these in a little bit of detail. And then I'll talk about a case study where we sort of use this model with some real data. So understanding needs, who's at risk? So you need to understand, are these women? Are these children? Are these the aged? Who are these people? Where do they live? What are their lives like? How do they access the health system? How does the health system interact with them in terms of triaging them up the ladder from a peripheral center to a district level to an urban center? What is the current intervention? If it's for STDs, are they doing syndromic management? So what are they currently doing, and how do they allocate resources towards that intervention? And then how is the intervention delivered? Is it delivered by a doctor, by a nurse, by a community health worker? And where does it happen? And then for best practices, who decides locally and internationally? So who's the gatekeeper who decides why, when, where, and how they do things? It's really important. So you have to understand all these things before you go about designing something. And then incentives. Obviously, we have to figure out ways to, as I mentioned earlier, incentivize the commercial sector. So we need to get people in the commercial sector to realize that there's gold to be mined in the hills. There's a profit motive here that's sustainable and real. Or there's a PR gain to be had through doing this in developing world areas. And there's a philanthropic gain. So not all companies are saying, we only do things for money. Most of them are. But they are also, there are several ways to get at people to get them interested in this. PR gains are particularly important for large companies because they see the value in spreading brand, for example. This is not cynical, this is just real. Then we need to talk to public sector gatekeepers. So we need to talk to ministers of health. We need to, if it's a decentralized system, for example, let's say in India where you have the municipalities, the states have a lot of autonomy about what they buy, how they ship it, how they deliver it, what people do. You need to talk to people in procurement and at every link along the value chain to understand what they value, how they go about making decisions, and most importantly, how they go about changing their mind about things, and how glacial that process is, and what barriers there are to doing that. Healthcare providers, so you need to talk to clinicians to understand what they do, and then to think about developing something that empowers them in a certain way. I feel that a big problem in peripheral clinics especially is that clinicians don't feel empowered to actually manage their patients actively. And then end beneficiaries. You have to have the push of getting a technology to a country, and you have to have pull of end beneficiaries saying, yes, we want this. So you have to talk to patients as well. And you have to find ways to make it worth their while to wait in line to get the service. So this, and for the private sector, we have this guiding principles for partnering, and it basically says that if we're going to work with a private sector company, they have to guarantee availability, accessibility, and affordability. So availability means if someone's developing a syphilis test for us and there happens to be an outbreak of syphilis in New Jersey and they get reimbursed for that by a third-party payer, they can't say, sorry, we can't send any syphilis tests to Bangladesh this month because we got this outbreak in New Jersey. So they have to commit to stable supply. Accessibility means they can't just sell it in capital cities. They have to actually commit to getting these things out comprehensively. And then affordability, which is obviously a relative and loaded term, but they need to be able to meet a price point that we determine together. So PATH, in the end, to work with a company has to have willingness by the company to really meet a price point for the public sector in the developing world. They can sell it for whatever they want in the private sector. The public sector that serves the poor, they have to meet a price point that we determine. And then private sector needs, we understand that they need to make a profit. So, and this is another thing that makes PATH a little bit different than other NGOs in that we are very much understanding of the fact that companies need to make money. And that actually companies are some of the best at marketing and changing people's behavior. So we want to leverage that. We want to use that, use that vehicle for moving things closer to patients. And we understand that it won't live unless someone's incentivized at the commercial end to produce it and distribute it and market it. So evidence, new technologies are disruptive. And so to be successful, you must demonstrate a savings or gain in lives. So you obviously want to prevent suffering and death. You want to save money if you can. You want to save time or work. And at the provider level, this becomes, or at the lab technician level, this actually becomes really important. And then political or social capital. You want people who are in positions of power to have a voice and feel like this is something valuable for them, for their political careers and for the health of their populations. And then systems. First thing we want to do is improve awareness. So we want people to understand the problem. We want people to understand what they might be able to do about it. We want to help, if we can, improve logistics. So figure out ways, either through the way we design a kit or through actual nuts and bolts ways of moving things from place to place, improving the way things move things around between places to make them more efficient. Infrastructure, so figuring out ways, simple ways to have better facilities for carrying out some of these assays, for example. Human capital, so we want to train people to do these things correctly. We don't want to just drop them out of a parachute with a kit insert and say goodbye. That's the worst thing we can do. We actually want to be there to do QA and QC, do QA on the beginning, the middle, and the end of a study period, for example, and helping people to see the value of this often means getting them to feel empowered by doing it. So, and then human organization. How can you arrange the humans to give more efficient information in real time, in faster time, for less money, in an easier or simpler way? So just to go back, there's need, there's incentives, there's evidence, and there's systems. So those are the four things that we really think about. It starts with the need, and then we really build this from day one of thinking about this from a multidisciplinary approach of building incentives, building evidence, and making suggestions about systems. So I'm going to talk about cervical cancer as a sort of crucible for this, because it's a project that actually took on this comprehensive framework. Obviously, many of you in this room probably know a lot more about cervical cancer than I do. But cervical cancer is the second most common cancer among women. It's responsible for more than 300,000 deaths, but I actually watched Laura Kautsky's presentation on the web, and she said 500,000. I didn't have time to change my slides. But 80% of these are in the developing world. It's caused by human papillomavirus. And screening, when it's done, is by PAP or by visual inspection, either with acetic acid or with Lugol's iodine. Is not very sensitive or specific, and requires things like specula and visualization approaches that are non-trivial. So our goal was to develop 2 HPV diagnostic tests for the developing world because they, up to now, don't exist. The developed world has them. Digene, or QIAGEN now, has made the hybrid capture assay for screening the major oncogenic types of HPV, but there's this sort of barrier to getting these things out to the developing world for a lot of reasons. So that's the need, and that was our goal. Incentives, 2 commercial partners, one being Digene, another being the Arborvita Corporation, agreed to develop HPV diagnostics that filled sort of different niches. One was more of a mass screening campaign, sort of ELISA plate sort of setup approach to mass screening campaigns. The other was more of a point of care, individual patient screening tool that you could use in the periphery. They agreed to do this. In return, we agreed to defray R&D costs. So we agreed to talk to donors about getting money to reduce some of the financial risk they were taking on by making tests that were suited for the developing world. We agreed to provide biological samples during R&D because I'm sure, as many of you know, cervix of a woman in Kenya is different than the cervix of a woman here in Seattle. And if you're going to sell the test in Kenya, you need to understand from biochemical perspective issues related to sample collection, and then also the different vaginal flora, for example, vaginal and cervical flora, understanding that when you're designing the test, not afterwards, not when you launch. Market assessment, so these companies were excited to be involved, but their goal is really to sell these to wealthy people in India, China, Russia, and Brazil. So the private sector. So we agreed to do some market assessments with them to better understand how they might penetrate those markets at the same time. Because every test they sell in the private sector will end up defraying, because of economies of scale, defray the cost of the public sector. It's an important thing to think about. And then we would do advocacy with key stakeholders. So people who are involved in cervical cancer campaigns, we would advocate with them to let them know what we were up to. And then we would do clinical evaluation of their prototypes. So we'd be this sort of unbiased party that would go out and do evaluations in clinical settings where the test would be used in the future. And in return, they agreed to develop the products, obviously, and then to manage and protect their IP. Open source, by the way, is not necessarily the best way to go for developing technologies for the developing world. And there's a lot of reasons for that, and I can talk to people about that afterwards. But they agreed to manage and protect the technologies they were developing. And a key here is that they agreed to apply for international and local regulatory approvals. Now, you think we put down a list of it's probably 70 different countries. So going through the process of getting local regulatory approval in country is a huge, huge task. And they agreed to do this, which was key for us because we want the countries to go in with their eyes open if they're going to take this on. They need to sell the technology at an affordable price as determined by PATH in key markets. And then they need to supply the test for 10 years to developing country markets. So for 10 years, they're locked in to making sure that this is available, affordable, and accessible. So not a bad deal, I don't think. And then evidence. Through clinical sites in India and China, we collected over 28,000 clinical specimens. So everything from provider-collected cervical swabs to self-collected vaginal swabs. We also nested in studies on cervical lesions and progression to disease to develop an evidence base locally so people understood the phenotypic presentation along with the probabilities for presentation to end-stage disease. But 28,000 clinical specimens, which we've divvied up among the commercial partners so they can actually use clinical specimens during R&D, really critical. Cost-effectiveness studies, so we wanted to understand if we were to launch this at certain hypothetical price points, in terms of morbidity and mortality prevention, what kind of return on investment is a Minister of Health going to get for every dollar or rupee or whatever shilling they invest in this technology? So, and this is something that's really important, and being fiscally conservative is something that comes up in the first couple minutes of discussions with stakeholders about your new technology. And then we're doing clinical evaluations of advanced prototypes with about 4,000 and 6,000 women, respectively, in India and China. India and China, because these are going to be the first markets that they launch, and from there, we're going to be doing studies in other areas of the world. Systems, we've spent a lot of time, PATH's been involved in the Alliance for Cervical Cancer Prevention. So we've been characterizing screening contexts all over the world for nearly a decade. So we have a lot of information about how women and providers come together to collect the swab or the target, and how it gets either interpreted and then disseminated and healthcare is delivered. So, and you'd be surprised at how variable and heterogeneous that is from country to country and from region to region. We're embedding new tests that are in screening campaigns. So these tests that we're evaluating are being run in parallel to screening campaigns that already exist. So we're going to be able to compare to what they're already doing, which is important because you can show the potential attributable benefit here. We're developing kit reagents that don't require any refrigeration, and we're simplifying the user interface of the test kits. So we're basically, and actually I can show it to you on the next slide. So the hybrid capture 2 assay for Digene, it works with a benchtop unit, has a lot of pipetting steps, requires refrigerated reagents. So the R&D that we did with Digene, we have a battery-operated reader device, which is the blue box. That's about the size of my laptop here. We have no pipetting because consumables are difficult to procure and difficult to keep clean. We only have dropper bottles. So you have to make an assay that's forgiving enough that you're going to get some volumes off from time to time. And we have relatively quick turnaround time. So in less than a day, you can run a 96-well plate. So with controls, probably 80 specimens. So manufacturing is scheduled for this in 2009. And then we've actually already started, many of you who are in academia can understand this. You write a grant to get another grant. But we have a follow-on project to actually, now that the product has been, a single product that has been developed, to really drive it towards the consumer and develop evidence base so people can make decisions locally about taking this on. And then we're doing advocacy in places like India and China. So to finish up, innovation is the easy part, actually. Making these tests but it's not even that easy. Innovation is the easy part of this whole thing. I guess that's me wearing my anthropology hat. It's like the hard part is to actually get people to take these things on sustainably. I didn't know how that would go off in a lab medicine grand rounds, but I wanted to make that clear that the innovation is an important part of it. Obviously, it's critical, but getting that boulder rolling and getting the momentum started for people to actually believe that this is worthwhile is difficult. The public sector in the developing world they're not usually early adopters of new technology. So they're not going to be the ones that say, you have a speculative new thing. Let me take it on and see how it works. And for several years, we really worked on that sort of economic model that it would sort of trickle back from the private sector to the public sector, and that consumers would get this idea that there's this new thing out there, and they would start to demand it from their public health providers, and then there would sort of be this momentum that would grow up naturally. And it doesn't happen. It really doesn't happen. And then short-term trade-offs and opportunity costs resonate with local stakeholders, especially given the tenure of politicians in the developing world. They want results in less than 5 years. When in actual fact, to see results from a lot of these things, you're going to need 7 to 10 years at minimum. Benefits are always relative. They're always relative to what you were doing in the past. So if someone's, for example, doing syndromic management for STDs, that may have low upfront costs. It may have high downstream costs to the population. But you have to understand the allocation of resources to what they're doing now compared to what you're proposing. And then end beneficiaries, the patients, their needs matter, and you need to know those needs early on as you develop. And then you need to go out iteratively to show prototypes to people, so you can get a feel for whether or not the specimen you're collecting is acceptable, whether or not the time to return of results is acceptable, and whether or not you can put it at a price niche that fits people's ability and what the value is they place on these technologies. And then advocacy, I mean, I'm sort of like a broken record here, but advocacy is required before, during, and after research and development. Demonstration studies, I can't emphasize this enough, are invaluable to building demand. So you want to demonstrate these things locally in places where you want these things to be taken up for a lot of reasons. You want to develop, from PATH's perspective, we want the best technology out there. So if our technology is not the best, we will advocate for a different technology. But you want to, this is an incredible way to create local champions and to have locals in their own voice create a story around why this is important. User-centered design is most effective in that when we put these things in front of people, the things that we take for granted as being intuitive are not necessarily intuitive. And then technologies with applications in the developing world are most quickly absorbed by the developing world. So cervical cancer screening is a good example of that, in that there's a large market here for that, growing market, especially given the vaccine. So companies are more willing to get involved. And also local countries, local regions are more amenable to the idea of taking these things on. Okay, I think that's it. I think the discussion maybe will bring up, I blew through a lot of this stuff, so I'd definitely like to hear people's questions and comments.
Questions for Dr. Steele, Dr. Barry?
Yeah, hi. I had two questions, somewhat related. One is with the case of the HPV testing, do you worry at all about, for a test like that has a reasonable prevalence, of developing a cheap test that's going to discover a lot of disease and then require much more expensive follow-up in a large number of people? So that's just actually might even be increasing costs in general. And then the second question is, when you negotiate a cheaper cost for the third world, can that cost, do you ever negotiate for the poor people in this country, say, which is a rich country, but we still have areas of need here?
Yeah, well, you know, I guess I'm supposed to repeat your first your question. So I guess your first question was, do you create actually a situation where people expend more resources because they find out they gather information that they otherwise didn't have, correct? Yeah, well, I guess that's kind of our goal at a certain level, is to create. I mean, all this is creating better information, given that no matter what people have, no matter what setting you're in, you're always going to have incomplete information. Flip side of that is that we are looking at, for example, cryotherapy is a common way to remove cervical lesions. In the background of all this, we're trying to develop simpler and cheaper ways to do cryotherapy, for example. So the diagnosis and the intervention, we're trying to marry those two in a way that actually fits the intervention and the problem locally. I would say, though, that when you look at it from a disability-adjusted life years perspective, for example, the amount of morbidity and the cost of mortality, let's say to a family where a mother dies of cervical cancer, if you went out and you did a really fine-grained model of that, the costs are going to be actually much higher than you would expect. So but the onus is on us to create that model. So I agree with you that there are issues there that people say, well, for example, we worked on diagnostics for dengue. People say, well, why are you giving me a diagnostic for dengue? I can't do anything about it. And the patient's still going to want antimalarials. So what do I do, right? So you create this evidence base. So you're right, in the background, you do have to create solutions that go along with the discovery of these new conditions. The second one was on...
Poor people in this country.
Yeah, and that hasn't been our focus, actually, to do... What's that? Oh, the question was, do we actually negotiate preferential pricing for poor people in this country? And we actually haven't tackled that at all. Part of that is because of the Medicaid and Medicare sort of tangled web of trying to disentangle that. I think is beyond what we're capable of, to be honest. And that being said, I think that you're right. I think there are areas in the U.S. that are very, very much, they very, very well approximate developing world settings. Rural areas, urban areas, we see that frequently. In fact, we had people from Emory contact us this past year saying, I really want a rapid diagnostic for gonorrhea because for an inner city population that I'm working with, I'm seeing this explosive growth of new cases of gonorrhea, and I want to be able to diagnose them and treat their partners right on the spot, because once they go away, they go away. Well, it's like deja vu. You hear the same thing in the developing world, right? So we are seeing a lot of parallels. And given that 2008 is probably going to be a recession year, those problems are going to be even worse, I think. They're not going to be getting better. The proportion of poor who are without services is growing in our country.
Could you give us an idea of sort of the top half dozen countries in the world where you're operating either by employees or projects, or some sense of where the big places are for your work?
So this is the top half a dozen countries that we are working in. We have projects. So let's see. Our biggest office is in India, and we have about 100 employees there, and we have a wide variety of projects. I would say India, Ukraine actually is a large office. The former Soviet republics are really interesting places to work, and as you know, life expectancy is going down pretty precipitously. Place like Ukraine's having an ejection drug use, HIV epidemic, along with hepatitis and TB. So India, and these are in no order: India, Ukraine, Kenya, parts of Southeast Asia. So I would say that Indonesia, Thailand are probably in a tie somewhere in there. Tanzania, South Africa. Oh boy, yeah, that's probably the tops right now. I could be wrong. Oh, we have a small office in Peru, but that's not in the top 5.
You had a question?
Do you ever find it's necessary to sort of, in order to obtain access to certain technologies, to provide a sort of a piggybacking center within companies in order to give them access to your networks in order to use their technology to develop diagnostics for infectious diseases?
So the question was, do you ever have to give people sort of the keys to the store to get them to, or whatever, the keys to the car to get them to come in and go for a ride or whatever? Well, can you piggyback? Can you give them access to other things by virtue of being involved in one thing? I would say no, because it's almost implied though, because to get these things lifted off the ground, we are leveraging all of our networks to make these things even happen in a small way. So I think that it's implied, and these projects are long term. So the Cervical Cancer project is 5 years with another 5-year follow-on for launch and for uptake. So through that process, through any collaboration, you're going to have these sort of serendipitous times where you're developing new ideas for new projects or new products that could layer on to things you're already doing. And if we can do it in a cost-effective and non-disruptive way, I think we're not averse to that. So.
I was wondering what percentage of companies who you collaborate with who do manufacturing for you turn a profit on that?
A large. So what proportion of companies that we work with turn a profit on the work that we do together? A large proportion of the ICS tests, so the lateral flow pregnancy strip type tests. Those companies are financially solvent and are making a profit on every strip that they create, partially because we've helped to facilitate demand that gets them a non-negligible return on every strip they create. So the companies that we've worked with in India, for example, there's 3 or 4 that we were actually very involved with at the very beginning of launching sort of a rapid strip test diagnostic industry in India, have gone from 4 or 5 employees to 800 to 1,000 employees each. So there's been in the last decade, there's been a really exponential growth. Some of the other technologies have not been as successful. In fact, for example, for diseases, for surveillance, for example, we've developed a surveillance tool for vitamin A deficiency. And as you can imagine, countries are going to think about this and think, well, why don't I just give people more vitamin A supplementation instead of going out and measuring it? Well, there's trade-offs there, and for surveillance tools, the markets aren't as big than in the curative market. So we've developed a vitamin A deficiency monitoring, and the demand has been fairly light. But on the front end, we've done our best to ameliorate risk for them, so they're not putting all their eggs in this basket, because we obey the same principles that biotechs obey, which is, if you're doing things like baseball odds, in terms of proportion of success, you're doing pretty well. In fact, I think we're much better than biotechs. But There is a high rate of failure, which means we have to have a high rate of new idea generation.
In the back there.
Could you comment briefly on your approach to HIV viral load monitoring and kind of where you are in that, developing that assay?
Sure. So you wanted to know about HIV viral load monitoring and where we are with that assay. Actually, we were working with you on that assay. So that's like a lob from the crowd. This is a great question. So we are, we've been in touch with Lisa Frankel and others about developing simpler ways to understand the level of viremia in patients at or near the point of care. We are currently searching for new sources of funding, but we think we actually have secured funding to move this forward in an R&D way. We've selected reagents, some reagents, at least a short list of reagents, and we are hoping in the next 4 to 6 months to move forward. So.